Disseminated intravascular coagulation, or DIC, is a harrowing medical enigma. It is not a disease in itself, but rather a formidable complication arising from a constellation of other disorders. Imagine a delicate scale, carefully balancing the body's ability to clot and bleed. DIC throws this delicate balance into disarray, triggering a cascade of events within the bloodstream. Our blood vessels, the intricate network that sustains life, are normally smooth and conducive to the seamless flow of blood. DIC disrupts this harmony, turning the very vessels meant to sustain us into treacherous terrain. Blood clots, typically the body's protective mechanism to stem bleeding, form inappropriately throughout the circulatory system. This rampant clotting depletes the body's clotting factors, the very proteins essential for staunching bleeding. The consequences are dire. As clotting factors dwindle, uncontrolled bleeding can erupt, transforming even minor injuries into life-threatening hemorrhages. Simultaneously, the widespread clotting obstructs blood flow to vital organs, potentially leading to organ failure. DIC, therefore, presents a terrifying paradox, the simultaneous occurrence of clotting and bleeding. Understanding DIC requires delving into the intricate world of the coagulation cascade, a complex series of chemical reactions that govern blood clotting. In a healthy individual, this cascade is tightly regulated, activated only when necessary to repair vascular injury. DIC, however, hijacks this intricate system, thrusting it into overdrive. The triggers of DIC are varied and often catastrophic, ranging from severe infections and traumatic injuries to malignancies and obstetric complications. These triggers unleash a torrent of procoagulant substances into the bloodstream, overwhelming the body's natural regulatory mechanisms. The result is widespread activation of the coagulation cascade, leading to the indiscriminate formation of blood clots within small blood vessels throughout the body. As these microclots proliferate, they consume clotting factors and platelets, the cellular components crucial for clotting, at an alarming rate. This depletion of clotting factors and platelets sets the stage for the paradoxical bleeding that characterizes DIC. The body's ability to stem bleeding is compromised, making even minor injuries a cause for grave concern. DIC is not a standalone entity, but rather a harbinger of underlying chaos within the body. Unraveling the triggers of DIC is crucial for effective diagnosis and treatment. Among the most common culprits are severe infections, particularly those caused by bacteria that release toxins into the bloodstream. These toxins can directly activate the coagulation cascade, setting the stage for DIC. Trauma, especially massive tissue injury, is another potent trigger of DIC. The body's response to trauma, while essential for survival, can also unleash a cascade of inflammatory mediators that activate the coagulation system. Malignancies, particularly certain types of leukemia and adenocarcinoma, can also predispose individuals to DIC. These cancers often release procoagulant substances into the bloodstream, disrupting the delicate balance of coagulation. Obstetric complications, such as placental abruption, amniotic fluid embolism, and preeclampsia, pose a significant risk of DIC in pregnant women. These conditions can release tissue factor, a potent activator of the coagulation cascade, into the maternal circulation, triggering DIC. Immune disorders such as systemic lupus erythematosus can also lead to DIC by producing antibodies that target and activate components of the coagulation system. Diagnosing DIC is akin to solving a complex puzzle, requiring a combination of clinical suspicion, meticulous laboratory investigations, and a thorough understanding of the patient's underlying condition. The presence of bleeding, especially from multiple sites in a patient with a predisposing condition, should raise immediate suspicion of DIC. Laboratory tests play a pivotal role in confirming the diagnosis. A complete blood count often reveals a low platelet count, reflecting their consumption in the myriad microclots. Coagulation tests such as prothrombin time and partial thromboplastin time typically show prolonged clotting times, indicating a deficiency of clotting factors. Fibrinogen, a key clotting protein, is often depleted in DIC and its levels can be measured. D-dimer, a breakdown product of fibrin, is often markedly elevated in DIC, reflecting the ongoing process of clot formation and breakdown. Examination of a blood smear under a microscope may reveal the presence of schistocytes, fragmented red blood cells that are sheared as they navigate the turbulent blood flow created by microclots. Treatment of DIC is multifaceted and hinges on two fundamental principles: addressing the underlying cause and providing supportive care to stabilize the patient's condition. Identifying and treating the underlying trigger, whether it be an infection, trauma, malignancy, or obstetric complication, is paramount to halting the DEC cascade. Supportive care often involves transfusions of blood products such as platelets, fresh frozen plasma, and cryoprecipitate to replenish depleted clotting factors and platelets. In some cases, particularly those with evidence of extensive clotting, anticoagulants such as heparin may be cautiously administered to dampen the overactive coagulation system. However, the use of anticoagulants in DIC remains controversial and must be carefully weighed against the risk of exacerbating bleeding. The prognosis of DIC remains guarded, with mortality rates ranging from 30 to 80% depending on the severity of the underlying condition and the promptness of treatment. Early recognition and aggressive management are crucial to improving outcomes. DIC is a race against time, a battle to restore balance to a system in disarray.
Is above about 140/90, what we call hypertension, and stays there, it can cause serious problems. That's because the extra strain on the arterial wall can produce small tears. When the injured tissue swells up, substances that respond to the inflammation, like white blood cells, collect around the tears. Fat and cholesterol floating in the blood latch on too, eventually building up to form a plaque that stiffens and thickens the inner arterial wall. This condition is called atherosclerosis, and it can have dangerous consequences. If the plaque ruptures, a blood clot forms on top of the tear, clogging the already narrowed pipe. If the clot is big enough, it can completely block the flow of oxygen and nutrients to cells downstream. In vessels that feed the heart, that will cause a heart attack when oxygen-deprived cardiac muscle cells start to die. If the clot cuts off blood flow to the brain, it causes a stroke. Dangerously clogged blood vessels can be widened by a procedure called an angioplasty. There, doctors thread a wire through the vessel to the obstructed site, and then pass a deflated balloon catheter over the wire. When the balloon is inflated, it forces the passageway open again. Sometimes a rigid tube called a stent is placed in the vessel to help hold it open, letting the blood flow freely to replenish the oxygen-starved cells downstream. Staying flexible under pressure is a tough job for arteries. The fluid they pump is composed of substances that can get sticky and clog them. And your typical healthy heart beats about 70 times a minute, and at least 2.5 billion times during an average lifetime. That may sound like an insurmountable amount of pressure, but don't worry. Your arteries are well suited for the challenge.